This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026, titled Bicentric Analysis of Repeated Retrosigmoid Approach for Recurrent Vestibular Schwannoma, Facial Nerve Function and Risk of Second Recurrence.
This is a topic that hits home for many of us. We know that vestibular schwannomas, or VSs, are typically slow-growing tumors arising from the Schwann cells of the vestibulocochlear nerve. While we've seen a shift toward observation and stereotactic radiosurgery as first-line strategies, surgery remains the gold standard for large, symptomatic tumors causing brainstem compression or hydrocephalus.
Exactly, Dr. Aris. But the challenge we're discussing today is the recurrence. Despite our best microsurgical techniques, recurrence or progression after an incomplete resection happens in up to 20% of patients. And when that happens, we are often left with a difficult choice: radiosurgery or repeat microsurgery.
Right. And the literature on repeat VS surgery is surprisingly scarce. Most institutional series show only a small fraction of patients, sometimes less than 6%, requiring repeat resection. That's why this bicentric study is so important. It gives us a larger data set from two major centers, the University of Leipzig in Germany and the Medical University of Warsaw in Poland.
It's a retrospective analysis of 35 patients with sporadic VS who underwent repeated retrosigmoid surgery between 2002 and 2024. They were very specific with their inclusion. Patients had to have had a previous retrosigmoid approach, histopathologic confirmation of VS, and radiological evidence of regrowth on gadolinium-enhanced MRI.
And they excluded NF2 patients. That's a key distinction for the residents listening. The biological behavior of NF2-related tumors is distinct, so keeping this to sporadic cases makes the data much cleaner for our general patient population.
Let's talk about the surgical technique first. Both centers used the retrosigmoid approach, but there was a slight variation in positioning. Center A used a supine lateral position, while Center B performed all surgeries in the semi-sitting position. Regardless of the position, they both followed a similar path: a curved dural incision, gradual release of CSF from the cerebellomedullary cistern to expose the tumor, and crucially, intraoperative EMG monitoring.
That neuromonitoring is vital in a reoperation. They were recording from the orbicularis oculi and oris muscles using bipolar stimulation ranging from 1 down to 0.05 milliamps. In a recurrent case, where you're dealing with scarring and altered anatomy, that feedback is the only thing keeping you on the right side of a permanent facial palsy.
Which leads us to the first major outcome: facial nerve function. They used the House-Brackman grading at the 3-month postoperative mark. Dr. Arist, what were your thoughts on their FN deterioration rate?
They reported that FN deterioration occurred in 11 patients, which is about 31.4%. For a repeat surgery, that's actually quite acceptable, though obviously a significant risk to discuss with the patient. But the real pearl in this study is why those 11 patients deteriorated.
Right. The time between the primary and the repeated surgery was the strongest predictor. In patients who experienced postoperative FN deterioration, the mean time between surgeries was only 42.4 months. In contrast, for those whose nerve function was preserved, the interval was nearly double, 81.2 months.
This is a crucial point for clinical decision-making. The study suggests that more aggressive VSs with shorter intervals between surgeries significantly increase the risk. They even performed an ROC analysis and identified a specific cutoff, 102 months. If the recurrence happens sooner than 102 months, roughly 8.5 years, the risk to the facial nerve during a second surgery is statistically higher.
It's almost as if the biological aggressiveness of the tumor makes the dissection plan more hostile. When the tumor grows back quickly, the scarring might be more intense, or the tumor itself might be more adherent to the nerve fibers.
Precisely. Now let's pivot to the other side of the coin: tumor control. We're going back in to stop the tumor, but how often does it come back a third time?
In this cohort, a second recurrence, so a third tumor event, was observed in 4 patients, or 11.4%. The median follow-up was 43 months. When they looked at the risk factors for this second recurrence, the volumetric extent of resection, or EOR, was the standout variable.
They used quantitative volumetric assessment from the 3-month post-op MRIs. This wasn't just a surgeon's subjective impression of how much they took out. The p-value for EOR was 0.011. And again, they found a very specific cutoff using ROC analysis.
The magic number was 62%,
An extent of resection greater than 62% was significantly associated with preventing a second recurrence. The AUC was 0.96, which is incredibly high. It had 100% sensitivity and 92.9% specificity in this study.
That's a very practical takeaway for a resident. You don't necessarily have to achieve a gross total resection in a recurrent case if the risks are too high. But if you can't get past that 62% volumetric threshold, the patient is at a very high risk of needing a third operation. It provides a target for subtotal resections, where we're trying to balance nerve preservation with mass effect.
There was another finding regarding tumor control that I found quite surprising, and it might be controversial. They looked at the role of adjuvant radiotherapy after an incomplete repeat resection.
Ah, yes. In many centers, the standard of care after a subtotal resection for a recurrence is to follow up with gamma knife or cyberknife. But what did this study find?
They found that adjuvant radiotherapy after incomplete resection was not significantly associated with a reduced risk of second recurrence. The p-value was 0.77.
That is a provocative result. It suggests that once a tumor has recurred after a primary surgery, its biology might be less responsive to radiation, or perhaps the local repeated surgery itself is the primary driver of further tumor control. The authors conclude that local repeated surgery appears to be of importance regarding further tumor control.
It really emphasizes the surgical in neurosurgery. If you're going back in, the quality of that second resection, specifically hitting that volumetric EOR of 62% or higher, is more predictive of the long-term outcome than whether or not you send them to the radiation oncologist afterward.
Let's recap the key points for our listeners. If you're looking at a patient with a recurrent vestibular schwannoma and you're planning a repeated retrosigmoid approach, first, check the clock. If it's been less than 102 months since their first surgery, warn them that the facial nerve risk is significantly elevated due to the likely aggressive nature of that regrowth.
And second, once you're in the OR, your goal should be a volumetric resection of at least 62%. If you achieve that, the risk of a third recurrence drops significantly.
This study really highlights the clinical challenge of these cases. Re-resection is a balance. We're operating in a field of scarring and altered anatomy, but with the retrosigmoid approach and diligent intraoperative EMG monitoring, we can achieve favorable tumor control with acceptable facial nerve outcomes.
It's also worth noting the bicentric nature of the study. Seeing these trends hold true across two different centers, one using supine positioning and the other semi-sitting, gives the data a bit more weight. It suggests these findings aren't just a result of one specific surgeon's habit, but are likely tied to the pathology itself.
Absolutely. For the residents, remember the specifics. House-Brackman for FN braiding, 3-month post-op MRI for volumetric EOR assessment, and don't assume radiation will fix an inadequate second resection.
This was a deep dive into a rare but critical surgical scenario. The study's conclusion is clear. While challenging, repeated retrosigmoid surgery is a viable and effective strategy for managing recurrent VS.
Well, that's all the time we have for today. I'm Dr. Aris.
And I'm Dr. Alara.
Thank you for joining us on the Neurosurgery Hub podcast. Keep honing those microsurgical skills, and we'll see you in the next episode.